Hello everybody, I'm Dr. Fuad Khan and today we're going to discuss a capacity consult. What is a capacity consult? Well, it's an attempt to make sure that the patient has the ability to make an informed decision about his or her health care. What is informed decision making? An informed decision making is when a person is fully aware of what the situation is, has an understanding of all the possibilities that he or she can do to handle that situation, and then he or she makes a rational choice based on all that information available. So if you look at it, you require about three things. Three things is, one is access to information, the second is the ability to understand that information, and third is to rationally make that decision. So that is the whole process of an informed decision making by the patient. Let's talk about two commonly used terms, capacity and competence. These are often interchangeably used, but I want to be very specific here. Capacity is a medical term and competence is a legal term. Capacity is all about the potential of the patient to understand, whereas competence is the decision by the court that the person is able to discharge or execute a certain decision. Let me give you an example of a jet engine. Let's say if we ask the engineers, does this engine has the capacity to take the airplane up in the air? They may say, yes, it has the capacity, or it doesn't. But then it's upon the airline management to say the airplane can go ahead and execute the action, which is that it can take off. Let me talk about two properties of capacity that are extremely important to understand. First of all, capacity is never static. So a person who did not have capacity yesterday may have regained capacity today. The second important property is that capacity is very specific. So a person who may have capacity for one thing does not guarantee that they may have capacity for another thing. Let me give you examples. A person who was delirious and you evaluated the person today, you would document at this time the person does not demonstrate capacity, etc. Then tomorrow the person is better, you say a previous evaluation conducted showed the person did not have capacity at that time because of delirium, and now since the delirium has improved, a repeat evaluation suggests that the patient has regained capacity. The other important property is, let me give you an example. So a person who is not able to understand a clinical intervention the team is proposing and does not demonstrate clear-cut thinking process around that intervention and cannot give you a feedback as to what is the process and what is the risks or benefits of that, may not have capacity to decide in favor or against that intervention. However, if asked about going home to a nursing home or his child's home or his own home, and he can give you complete answers, a proper rational thinking process of why he wants to go home or not go home, then he or she may have capacity for a disposition site. So I want to emphasize again, neither static nor generalizable. So it's very specific. Let's talk about who is the best person to do a capacity evaluation. It is often thought that it is in the domains of psychiatry only. Well, let's give it a little thought. What are the three very important things that need to be understood when a capacity evaluation is being done? One is that there's a clinical situation with an untreated course, then there's a proposed plan by the team, and then it's the patient's involvement, engagement, and ability to participate in a capacity evaluation and treatment plan. Now, if you look at it, all these three are the best known to the primary team of the patient. So the primary team physician or physician extender, any provider, should be able to do a capacity evaluation. It's often described in bylaws of the hospital, but almost always all providers should be able to do a capacity evaluation. It's part of their skill set and it's expected of them because they will do a better job. Now, when do you ask other disciplines to get involved? For example, psychiatry. Psychiatry makes a lot of sense because there's a lot of psychiatric conditions that actually create an impediment in the patient's ability to engage, understand, or fathom the problem. For example, acute panic, severe anxiety, depression, psychosis and delusions, or maybe withdrawal from a substance that the person had been involved in, or any other things such as maybe neurology can help with, such as aphasia or a stroke or a hemi-neglect, or maybe a locked-in syndrome, anything like that. In those cases where there's suspicion that either psychiatry can help understand why the person is unable to participate in informed decision making, and maybe also help in improving the situation by making a psychopharmacological or other behavioral intervention or recommendation, which will improve the outcomes of a capacity evaluation. So there is good reason to get a secondary evaluation of capacity from behavioral health, but it has to be secondary and it has to have a specific concern that there is a psychiatric phenomenon going on. Now we are going to talk about the capacity evaluation process. Let's divide it into three sections. One is before capacity evaluation, then the capacity evaluation itself, and then what do you do after a full capacity evaluation. Let's talk about the first one. Before capacity evaluation, if you are a consultant who's been asked to do a secondary evaluation of capacity, you really need to know three things. What is going on? What is the treatment team trying to propose? And what is the specific question? Now, if you are the primary team, you ought to know all of this. But if you're requesting that a consultant come in, it's your duty to inform the consultant and appraise them of all what's going on, what the treatment team is proposing, and what's the specific question. Let's talk about the technical process of capacity evaluation. So again, I'm going to divide it into three portions. One is your interview of the patient so that you can understand what he or she understands. The second one is your analysis of the patient's understanding to be factual or not. And then the third is your opinion of capacity. Now let's go to the first one. When you interview the patient, you should look at these 5 different parts. Number 1, does the patient show engageability? Can you engage the patient, and does he have a good rapport with you during this time? A sedated, angry, violent, comatose patient obviously will not qualify for that. The second portion is you trying to gain an understanding of the patient's understanding of what's going on. Typically, my questions are, tell me why you're here in the hospital. Tell me what's going on. And if you don't get treated, what's going to happen? These questions usually tell me a whole lot of what the patient thinks. Then I ask the next question. Do you know what the treatment team is suggesting? First of all, they have to tell me what the treatment team is suggesting. And then I ask them, what do you think? If you agree with their plan, what are the risks and what are the benefits of agreeing with that plan? They should be able to give me something. Once the treatment plan portion is done, I go to the other one, which is, do you have any other alternatives? Especially if the patient is refusing, they usually have alternatives. Oh, I will do this, I will do that. And so I ask them, what are other alternatives that you can have? And you come to the last thing, which is the patient's expressed opinion. You ask the patients, do you really want to go ahead with the treatment team's proposal or not? That concludes the interview, but then is your analysis, and you document your analysis. You compare what the patient said, you pretty much recorded it verbatim, and you compare it with the factual knowledge. So you have access to the treatment team's understanding. You also have access to the labs and other information about the illness. So you compare patient's understanding to the illness. You also then compare each one of the other items. Patient's understanding of the treatment team's plan, patient's understanding of the risks and benefits of that, and then you look at the patient's alternative. The alternative should be viable and relevant. For example, if somebody who has endocarditis and septicemia and says, I'm going to start eating healthy, that's not relevant at that time. So, the relevance and the pragmatism is all supposed to be looked at. And then you go ahead and say, according to my understanding and the clinical situation, the patient's understanding of the situation is accurate or not accurate. Now remember, any one of those 5 domains, the engageability, the patient's understanding of the illness, the patient's understanding of the treatment team's plan, the patient's own viable, practical, sensible alternative, and the patient's ability to express an opinion. If any one of them is absent, you basically are looking at a capacity that's not present. So every one of them should be present. So from this point onwards, we come to you making a judgment now, the final step. That's what you get paid for. You need to have a judgment there. So you will declare, looking at these things, that the patient has capacity or does not have capacity. This concludes the first part of our capacity evaluation. We have a second video where we're going to talk about what do you do after you've declared and passed your judgment that the capacity is present or absent. It would talk about emergency situations and what do you do when capacity is absent, or non-emergency situations. It will also talk about, if you determine that the capacity is absent, are you also recommending what to look for and what to do, in which the primary team can go ahead and look for certain outcomes and then be able to say the capacity is now regained. We're going to also talk about some tips and tricks, that how do you introduce yourself, how do you talk to the patient, how do you console the team, console the patient, etc. And finally, we'll also talk about some kind of rather challenging scenarios. How do you handle those and what do you do? So stay tuned and thank you for listening.